Good evening, everyone. Welcome to Understanding Hereditary Cancer Risk. Thank you very much to all of our patients, our caregivers, our advocates, and our guests for joining us. My name is Dr. Michael Hall. I'm the chair of the Department of Clinical Genetics here at Fox Chase Cancer Center. I just want to give everyone context. We were told just before we started that it sounds like there's somewhere between 250 and 300 of you who have registered for this event tonight. So thank you again so much for joining. I hope you'll find this informative. I think there's going to be a wealth of interesting information provided to you from my colleagues tonight. So tonight, my colleagues and I are going to share with you hereditary and environmental risk factors associated with a variety of cancers, as well as some of the preventive efforts directed at high-risk families. This has been one of the expertise of our department in this field for many years. And I think that you'll find that the experts we've invited here tonight who make up the members of my department are really a wealth of great knowledge. If you're watching this and you have a Facebook account, we encourage you to ask questions. You can ask questions via your Facebook account using the chat feature. And then those questions are actually going to be transmitted to me via my phone, by text, and then we'll be able to review those questions after the presentations. Of course, no events like this happen, first of all, without the person power behind this. And I want to thank the Fox Chase staff who put together this event for us. They really did the lion's share of the organization. I want to thank my colleagues who are here tonight, Dr. Mary Daly, who founded and led this department back in the 1990s, Dr. Kristen Whitaker, Dr. Elias Obeid, Dr. Rishi Jain, and Hannah Campbell, who is one of our newest genetic counselors, have all put in great time and effort to make this event happen, and I really want to thank them. I'd also like to thank our corporate sponsors for this event. Again, their support really is what is crucial to help make events like this happen. I'm going to run through the list. We had actually a nice time meeting everyone and hearing about what they do before this conference. But our representation is from AbbVie, from Caris, Foundation Medicine, Invitae, Myriad Genetics, Novartis, Pfizer, Promega, Puma Biotech, and Tempest. So thank you to all of these organizations that supported this talk and this presentation. I'd also like to thank 4 advocacy groups who took out time and reached out to us tonight for this presentation. They are Alive and Kickin', Bright Pink, Force, and Lynch Syndrome International. So without further ado, I know everyone's actually here to actually hear our experts. So I'm going to start by introducing my colleague, Dr. Elias Obeid, who I've known for a number of years now. Dr. Obeid trained at the University of Chicago in hematology oncology, and he finished that fellowship training in, I think, 2013, if I'm right. He has been with us at Fox Chase Cancer Center as an assistant professor since 2013. He's currently the director of our prostate risk assessment program. He's also a breast oncologist and has most recently, actually for the past several years now, been the interim chief in the division of breast medical oncology. So he's a busy man. He knows a lot, and he's an excellent teacher. So again, without further ado, I'll give the floor to Dr. Obeid.
Thank you, Dr. Hall, for the introduction, and thanks for everyone for joining this event. I'm really, really happy to be here with you and talk a little bit about prostate cancer risk. So to just go over what we know about prostate cancer, and I'll start first with talking a bit about risk. So if we can move the slides. So when we talk about cancer risk, most of the experts distinguish between 3 different risks. For us, we know about people who got cancer. But then we know that many people have cancer in their family, or they have a genetic predisposition to cancer, or somebody who doesn't have any cancers in their family. So if we look at somebody who doesn't really have a known predisposition, and this is where we see what we call general population risk. So this is a sporadic cancer that just occurs by chance. And then we see, individuals who, when they look at their families, they find a lot of different cancers. They get genetic testing, and we don't find anything to determine that they have a genetic predisposition. But there's a clustering of different cancers, or maybe the same cancers in their family, and that's what we call familial cancer. Today we will talk a little bit more about another category which is important, although it's the minor, the smaller proportion of those cancers, but those are the cancers that we call hereditary cancers, and those are the ones that occur because of a genetic mutation, an abnormality in the DNA that is passed on from a parent to their child. So, well, next slide, please. So with that said, so prostate cancer risk, is well recognized that when we know about prostate cancer, we see a lot of families with prostate cancer in their family. So this is what we have known about it. However, genetic testing for prostate cancer has only been incorporated in the last probably 5 years, widely. Previously, only a few individuals maybe might be able to get testing. But now, more recently, prostate cancer genetics has been more understood and more widespread and more available to individuals who would otherwise need it. Next slide. So prostate cancer screening is what everybody always is worried about, like how frequent should we do it? And I'll tell you that, about 3 decades ago, people started like talking about PSA and screening, and every man would get prostate cancer screening. Then about probably 15 years ago, 14 years ago, the pendulum swung on the opposite side, and individuals were encouraged not to necessarily seek prostate cancer screening. However, now things are moving towards more like a medium in between the two different extremes. And the part of it also is, we started to see a little bit of an increase in patients that are getting diagnosed with metastatic prostate cancer, but also recognizing that some individuals really need that screening. And especially those individuals who have a family history or have a known genetic predisposition to prostate cancer. For example, we know that those who have a genetic predisposition to prostate cancer would need to start early screening, not at 50, but we start around age 40, although it's not really a concrete number, but that's about the ballpoint where we start, or maybe 10 years before the youngest case of prostate cancer in that family. And their screening would continue to be annually. So that's every year they get a PSA, they get a prostate exam. And sometimes we might do more frequent PSA checks depending on the level of the PSA if it starts to fluctuate and go up a little bit. Next slide. So who should get genetic testing when they're concerned about their prostate cancer risk? So we know that all men with a known family history of a genetic predisposition, they should get genetic counseling and potentially getting genetic tested. Now, we also know now that men who already have a prostate cancer diagnosis should discuss with their providers whether or not genetic testing is needed, especially if they have metastatic prostate cancer. It's recommended for them to get genetic testing because their treatment might be a little bit different, or we have other things to add to their treatment. And also, we know that the decision about what to do for their cancers also is dependent upon the genetic test result. And of course, the test information is important not just for them but other family members, in their families. Next slide. So what we knew about probably 2 decades ago about prostate cancer genetics was mostly concentrated on the BRCA1 and BRCA2 genes, or many of you know them as the BRCA1 and BRCA2 genes. So those are the genes that are linked to breast and ovary cancer in women, but also they are linked to prostate cancer in men and some other cancers like pancreatic cancer and skin cancer type melanoma. But what we know now about BRCA1 and 2, and especially about BRCA2 mutation, is that they play a strong role in prostate cancer genetics. We know that those who have the BRCA mutations might have an earlier onset of prostate cancer diagnosis, a higher risk of getting prostate cancer, and even the prostate cancer is more of what we call the clinically significant type, the one that could become aggressive, and certainly we that need the attention, soon. So they're also more likely to have a high Gleason score, something that we rely upon when you look at prostate cancer, larger tumors, and metastatic disease, even at an early diagnosis. Next slide. So we also have seen, at least in one study, that although studies have looked at some ethnic variations, and we know that African American men are at a higher risk of developing prostate cancer. One study recently showed that among 1,000 men with a prostate cancer diagnosis, in a healthcare setting where all of them had an equal access to healthcare, the BRCA mutations were more frequently seen in African American men with prostate cancer at about 7.3%, and comparing that to about 2.2% in Caucasian men in the same group. So certainly it's an important finding, at least in one study, and hopefully we can understand a little bit more about the role of genetics in African American men and the risk of prostate cancer. Next slide. Now, as we learn about the BRCA1 and BRCA2, and we continue to learn on how to treat, we have had more understanding about other genes that are linked to prostate cancer. Among those, Lynch syndrome. Dr. Hall will be talking to you a little bit more later on today about Lynch syndrome. But those individuals who have one of those DNA mismatch repair gene mutations, we know that they have risk of certain cancers, but also now we understand that they have a higher risk for prostate cancer. Their lifetime risk can go up to as high as 30%, recognizing that the average or the population general risk is about 12 to 13%. Next slide. We also have learned about other genes, and I did not put a whole list except just a few here that we really know a little bit more about. And there's a host of other genes that we don't know much about, but they frequently come up when we look at genetics and prostate cancer. But among those are the HOXB13 gene. This is more recently found gene. And we know that men who have that mutation are more likely to develop an early onset prostate cancer. When you look at their families, they have a lot of prostate cancers. They actually do, fairly well, and their cancer is not that aggressive type, but certainly they are more likely to have the prostate cancer. ATM mutations are also mutations that are associated with an increased risk of prostate cancer, also a slightly more aggressive form of prostate cancer. And finally, CHEK2 mutations, similar to ATM mutations, have been also linked to an increased risk of prostate cancer in some studies up to 8-folds. Next slide. Well, this is very important for all of us, and it seems exciting, and all of us now think that prostate cancer, we need to get genetic testing. This has to be done, but also with counseling support. Not everybody may need testing, because we know that about 10 to 15% of prostate cancers have or involve a germline or genetic mutation. So not all prostate cancers have that genetic predisposition. And about 4 to 16% of those men with prostate cancer or at risk based on their family history, if they get tested, will have a genetic predisposition found on their test result. And also a positive test result does not necessarily tell us that there is something that they need to do something about, because some of the genes that we find, we don't really understand yet the extent of their involvement with prostate cancer or maybe other cancers. So always important to have some genetic counseling to understand those results. And even some of the labs don't really agree on how do we interpret that genetic change or the change in the DNA in our body. And finally, which I think is very important, our privacy when we do genetic testing. although genetic testing with regards to health insurance and non-discrimination is supported by a federal law, we call it GINA, or the Genetic Information Non-Discrimination Act. However, this does not cover or does not extend to life insurance, disability insurance, or even long-term care insurance. So it's very important when somebody is getting genetic testing to get some counseling so they can understand what they need to know before they get the testing and how to understand the results on the back end. And next slide. In summary, I want to share with you just what we discussed, that prostate cancer can be sporadic, and that's the most of this prostate cancers, general population, but also can occur in families without a specific inheritance pattern or just clustering in certain families. We call it familial cancer, or can be hereditary cancer, which is passed on from parent to child through a mutant or germline mutation. While only approximately just 10% of prostate cancer are related to genetic predisposition, up to 30% of the men with prostate cancer might be eligible to get genetic testing. So really, this is a big number compared to just about 5 or 6 years ago, when very few men were able to actually get genetic testing covered by the insurance at the time. And we know that germline mutations, especially the BRCA1 and 2, particularly BRCA2, are strongly associated with prostate cancer, more aggressive forms of prostate cancer, earlier diagnosis, and potentially shorter lifespan from prostate cancer. We also know about other genes that are also important and linked to prostate cancer, such as the HOXP13, Lynch syndrome, ATM, CHEK2, and other genes that we are learning about. And with this, I will conclude my introduction to prostate cancer genetics, and thank you everyone for tuning in today.
Thank you so much, Dr. Obeid, for joining us and for that great summary of the state of affairs of prostate cancer and genetics. I just want to remind everyone who's on the webinar that there is an ability to submit questions via Facebook. So we are going to have a question and answer period at the end. So if you have questions for Dr. Obeid, please submit those. I'm going to move on. It's my great pleasure to introduce my colleague, Dr. Kristen Whitaker, who's going to give our next talk. Dr. Whitaker is an assistant professor at Fox Chase Cancer Center in the departments of clinical genetics and hematology oncology. Her practice focuses on patients with breast cancer and patients at high risk for breast and ovarian cancer. Her research interests include understanding and addressing cancer health disparities, optimizing breast cancer screening for high-risk women, and improving communication of genetic testing results among families. Dr. Whitaker received her undergraduate degree from the University of Pennsylvania and her medical degree from Drexel University College of Medicine. She completed a fellowship in hematology oncology, as well as a master's of science from the University of Chicago, before joining the Fox Chase faculty a couple of years ago. So without further ado, Dr. Whitaker.
All right. Good evening, everyone. I'm very excited to be here and share with you guys just a little bit about hereditary breast cancer. And I look forward to answering questions in the panel session that will follow. So this is a topic I love to talk about. I think that over the last 25 years, we've really made dramatic improvement in our understanding of breast cancer. At one point, we really had identified the BRCA1 and the BRCA2 genes, and we thought that they really were the only genes we kind of really need to know about in terms of understanding hereditary breast cancer. But over time, we've learned that, there are several other genes that also can increase a woman's risk of breast cancer. And outside of just knowing that they have genes that increase a woman's risk of breast cancer, we've really learned about other cancer risks with some of these genes. And I think that's something that's surprising to a lot of patients when I do genetics talks or talk to patients in the clinic. So those are the things that I really wanted to kind of highlight with you. Our increased knowledge around which genes increase breast cancer risk, but also the other types of cancer risk that can come with some of these genes. Next slide, please. So just a little bit of an overview about hereditary breast cancer. So like Dr. Obeid mentioned to you, when we're talking about hereditary cancers, we're really talking about cancers that are caused by a genetic change that's being passed through the family. And when we think about breast cancer, hereditary cancers are going to be just a small proportion of the cancers that we diagnose, but in general, about 5 to 10% of the breast cancers that we diagnose are going to be from an inherited gene mutation in the family. So I think this is actually surprising to a lot of patients and family members because, we'll have women come in and they'll be very young with the breast cancer diagnosis and they'll say, I'm certain I must have something in the family. And the reality is most times we're not going to find a genetic cause to explain your cancer diagnosis. But we look for it because it's important for managing your cancer, but also for your family to know about it. So when we think about hereditary breast cancer, although we know BRCA1 and BRCA2 are not the complete story for understanding hereditary breast cancer, these genes are still the most commonly identified and most significant genes in terms of increasing a woman's risk of breast cancer. We think that this explains about 60 to 70% of the breast cancer risk that is inherited. But over time, we found a handful of other genes that also increase a woman's risk of breast cancer. And I'll talk to you about those a little bit tonight. Next slide, please. So just a little bit about BRCA1 and BRCA2. These genes I actually find that a lot of women and men know a little bit about. And I think it's because these genes, one, are more common causes of hereditary breast cancer. But I also think some of these genes have gotten a little bit more media attention over people's lifetime. I always kind of put this picture of Angelina Jolie up because she really did a lot in terms of raising awareness about the BRCA genes, but also about genetic testing. Back in 2013, Angelina Jolie was pretty much all over the media talking about the fact that she had a BRCA gene mutation and that she was making the decision to undergo what is commonly called a double mastectomy in order to reduce her risk of breast cancer and also having her ovaries removed to reduce her risk of ovarian cancer. And kind of as a consequence of this, awareness around the BRCA genes was raised, awareness around genetic testing, and also preventative measures were raised. So it was pretty powerful, kind of her media presence in this regard. Next slide, please. And then I think it's always really important, and what I find a lot of patients find surprising, and Dr. Obi touched on this some, is, a lot of times when men or women know about the BRCA genes, they'll say, oh yeah, I've heard of that gene and I know that it comes with an increased risk of breast cancer. Sometimes they'll also say that I know that it comes with an increased risk of ovarian cancer. But most times people aren't aware that these genes actually can come with risk of other type of cancer. So, the two cancer types that I think are surprising to some people are that, specifically for that BRCA2 gene, men who carry a BRCA2 gene can have a significantly increased risk of prostate cancer, as Dr. Obi mentioned in his talk earlier. And what's not shown on this slide here, just because it's a little bit older, is that if you have a BRCA1 or a BRCA2 gene mutation, you also can have an elevated risk of developing pancreatic cancer. So I think those risks related to pancreatic and prostate cancer oftentimes are surprising to people when they learn about this gene. Next slide. And I put this family tree here just to show you, because sometimes patients will say to me, they'll say, well, Dr. Whitaker, what kind of family looks concerning? Like, what in my family history would be concerning? And again, kind of with that surprise that having things like prostate cancer and ovarian cancer in a family with breast cancer, the idea that this would be concerning for a genetic mutation like a BRCA1 or a BRCA2 gene is surprising. So, I just show you here that essentially, for example, we could have a patient here who I'm seeing in clinic who's a 34-year-old patient with breast cancer. And then she tells me she has a family history where her mom had an early diagnosis of breast cancer. And then she had an uncle with prostate and an aunt with ovarian cancer and a grandma with breast. That would be a family that we would be concerned about potentially having, one, a genetic cause of cancer, but specifically something like a BRCA gene mutation. Next slide. And this list is not meant to be exhaustive, but really just to kind of summarize for you at this point, some of the other genes outside of the BRCA1 and BRCA2 genes that we know can increase one's risk of developing breast cancer. And again, just in the interest of time, I'm not going to go into it a lot of detail, but you'll see there is a handful of other genes that increase a woman's risk of breast cancer. And just to put this into perspective, a woman who has no genetic mutation, a woman who doesn't have a family history of breast cancer, is going to have about a 10 to 12% lifetime risk of breast cancer. If you were to have any of these genes shown on this list, You can have a risk that's just slightly elevated at about 15%, but you can have a risk that's even higher that exceeds 60% in some cases. So these genes, in some cases, dramatically increase one's risk of developing breast cancer. And the other thing that I always think is really interesting and kind of important to point out, especially when we're, talking about kind of getting histories of cancer in families and understanding why we do genetic testing, is to really point out that many breast cancer genes, just like BRCA1 and BRCA2, if you have these genes, unfortunately, we don't only get risk of breast cancer, we can oftentimes get risk of other types of cancer. So I'll point out, for example, PALB2, which is shown here, which if we have a genetic mutation in that gene, the woman could also have an increased risk of pancreatic cancer or ovarian cancer, a very similar case if you had a mutation in something like ATM. So just the big take home is that many of these genes have an increased risk of breast cancer, but other types of cancer as well. Next slide. And then just the final thing that I want to touch on, and just very quickly in the interest of time, is once we identify a mutation, the question becomes, well, what do I do now? So you just told me that I have these elevated risks of breast cancer that can be, up to 85% depending on your gene mutation. How am I going to manage that risk? So, the two kind of approaches for managing breast cancer risks really are kind of two different pathways. So one pathway would be that we say you do what we call intensified breast cancer screening. So basically what that means for most women is that you're going to get more frequent breast imaging. So instead of getting just the mammogram once a year, you're also going to get a breast MRI once a year. And the second thing it means is that you're going to normally start your breast cancer screening earlier than kind of an average risk woman. For some of these genetic mutations like BRCA1, we're starting breast MRIs as early as age 25 and mammograms as early as age 30. I always point out to women, because it really becomes a decision point when you have a mutation in terms of how you manage the risk, is that when you do this intensified breast cancer screening, you're not actually lowering your chance of ever developing a breast cancer, but you're really doing this to identify a breast cancer at an earlier stage that tends to be more curable with a better outcome. Next slide. And then, the alternative approach, if a woman said, well, I'd rather actually minimize the chance of ever developing a breast cancer, what would be kind of the best way to do that? And without a doubt, the best way to minimize the chance of you ever developing a breast cancer would be to pursue what we call bilateral risk reducing mastectomy, or what's commonly termed double mastectomy. And this is highly effective at reducing one's risk of developing breast cancer, up to about 95% reduction in developing breast cancer. So that's an alternative approach. So it's not necessarily one that's right or wrong, but they're just different ways to approach this risk. Next slide. And I'm not going to go over this in the interest of time, but I put this here just to tell you there are some guidelines which can help direct us in terms of which of these genetic mutation carriers tend to benefit from pursuing a double mastectomy. And like I said, I won't go over it in a lot of details, but this is something that kind of guides our conversation if you were to be identified to have one of these breast cancer gene mutations. Next slide. And that's everything I wanted to kind of cover with you guys today. And like I said, I look forward to answering your questions during the panel.
All right. Thank you so much, Dr. Whitaker. That was awesome. Again, please put your questions in Facebook and we'll be happy to answer questions at the end. There's already been like a whole great slew of questions coming into my phone, so I can't wait. So I'm actually the next speaker up, so I think I'll be introducing myself. I'll keep it brief, I promise. My name is Dr. Michael Hall. I am a GI oncologist with an interest in hereditary GI risk assessment. I've been on faculty here at Fox Chase Cancer Center since 2008, and I've been the chair of the Department of Genetics for the last several years. Today, what I'm going to talk about, I'm not going to use slides. I thought I would just do this free form, and my goal was to give the listeners who joined us tonight just some of the high points of things that have occurred in the recent years in hereditary colorectal cancer and hereditary pancreatic cancer, and why they're exciting and where I think this field is going. So in hereditary colorectal cancer, for those of you who may be watching this who aren't so familiar, we've actually been screening all colorectal tumors and endometrial cancers now for 10 years. It's almost amazing to think it's been that long. 10 years we've been screening all of those tumors from all patients who develop them for markers of a very common hereditary cancer syndrome called Lynch syndrome. That was pretty novel in the field when we started doing that 10 years ago. And it really has made a huge difference in helping us and other cancer centers around the country identify patients with Lynch syndrome. And now we know that if you take all colorectal cancers, about 3% of colon cancer is caused by Lynch syndrome, and about 2% of endometrial cancer is caused by Lynch syndrome. And the reason that's important is we increasingly have better knowledge of how to treat those tumors. One thing that has especially changed in the last several years, specifically on that point, is the emergence of immune therapy has been shown to be particularly effective in colorectal cancers, endometrial cancers, and other tumors that show the molecular changes in the tumor that are consistent with Lynch syndrome. So immunotherapy, I like to say to some of my patients, really put Lynch syndrome on the map. And we've seen some incredible abilities to treat these tumors in patients with Lynch syndrome. In some patients, and in some, even in my own practice, we've actually seen cures of some patients with Lynch syndrome tumors. One thing we've learned in the last several years from the Memorial Sloan Kettering group is that actually, if you test all tumors that occur in an adult oncology clinic for Lynch syndrome, you actually find that actually that you can identify Lynch syndrome in many types of tumors, even outside of the range of cancers that we commonly think of as Lynch syndrome cancers, which include colon cancer, stomach cancer, endometrial cancer, ovarian cancer. What they showed is even in rare tumors like mesotheliomas, which is a rare lung cancer, if you screen enough of these kinds of tumors for Lynch syndrome, you'll find it. And that research from a colleague of mine named Alicia Latham and Sophia Stadler and others at Memorial Sloan Kettering, I think is really pushing the field forward to understand how Lynch syndrome manifests both in common ways, but in rare ways. One thing that also has been learned in the last several years is, again, through this much greater testing of patients for Lynch syndrome and the decrease in cost of testing, the use of panel-based testing to look at cancer risk across a broad number of cancer patients, is we have been able to narrow in that the commonness of Lynch syndrome in the population is actually much more common than we knew it was 10 or 15 years ago. Today, based on some research out of a group from Australia, we can, with pretty high confidence, say that about 1 in every 280 people around the world carry a mutation in a gene consistent with Lynch syndrome. Again, when I first started in this business 10 years ago, we thought that estimate was closer to 1 in 1,000 or even higher. So we've learned more and more that Lynch syndrome is actually very common in the population, which raises the bar for us as experts in the field to be even more proactive about trying to get patients tested, because we know a lot about how we can prevent cancers in this population. Again, just on that theme, one other thing that's really changed a lot is that the cost of testing has declined dramatically in the last 5 to 10 years. Our power to test more genes has improved exponentially. We now routinely test people for sometimes 50, 60, 70 genes at a time, but the cost that we're paying per gene has plummeted. And I think that's a real benefit to our patients. One thing that a group from Ohio State has taught us is that if we do test, for instance, patients with colon cancer with a large panel of genes, we'll find, for instance, among the early onset colon cancers who are under 50, we'll find that about 8% of those individuals will have Lynch syndrome. But what we'll also find is that in colon cancer patients, we're also going to find a whole slew of other genes, even genes, some of the genes Dr. Whitaker spoke of, that Dr. Obeid spoke of, genes that we traditionally associate with breast cancer risk and other cancer risks, you actually also find in this high-risk colon population. And I think what that tells us and what we've learned is that genetic risk is a lot more fluid than we used to think it was. It's not like every gene is in its little individual box and there are the genes that cause colon cancer and the genes that cause breast cancer. There's a lot of overlap here. And by testing more broadly in patients who present with a rare situation like a colon cancer under 50, you don't see that every day. You actually not only pick up these high-risk colon genes, but you pick up lots of other common genes as well. And those genes can go on to benefit these patients in the future of their lives with their screening, but also their family members. And I think that's been a huge advance. There's also been a number of rarer colon genes that have been discovered over the last several years, and our colleagues who have supported this talk, who do the genetic testing through the commercial companies, have been quick to add these genes onto panels. So, again, 10 years ago, 15 years ago, when I started in this business, we had the Lynch syndrome genes and the genes associated with familial adenomatous polyposis. Now there's a whole bunch of additional genes that are tested, such as GREM1, AXIN2, NTHL1. These are perhaps many genes that patients who are watching us tonight have never heard of, but it gives us a better ability to really sort of dig deep into the familial risk and make sure that we're covering everything that we need to cover. The last couple things I wanted to say about colon cancer before saying a couple things about pancreatic cancer is that it's been an exciting time for prevention. We should have data coming out next year, updated data on aspirin as a preventive product for patients with Lynch syndrome. There's also going to be a couple national trials of vaccine therapy in Lynch syndrome. We should be a site in one of those trials run by MD Anderson Cancer Center. For all those Lynch syndrome patients who are out there who might be interested in that, please keep us in mind. We will distribute that information via our newsletter when that trial comes up and is available. I want to switch just to hereditary pancreas cancer for a few minutes. One, I think, huge, amazing thing that has changed in the field of hereditary pancreas cancer is that in the last couple years, the NCCN guidelines began endorsing genetic testing as a routine part of the standard clinical care of patients who are diagnosed with pancreas cancer. Part of this was because we know that the BRCA genes play an important role in pancreas cancer risk. There are also new targeted therapies, olaparib and others, that can be used in patients who have pancreas cancer who have these germline mutations. So that was, again, a huge change for us in GI oncology to test all of our patients with pancreas cancer with a germline panel test. There is also, again, increasing information about other genes in pancreas cancer. So although the BRCA genes, like I said, are very relevant, with panel testing, we also find genes like ATM, which is also implicated in breast cancer risk. I think Dr. Whitaker mentioned that gene as well. Dr. Obeid mentioned it in prostate cancer. There are also other genes like PALB2 and others. And again, if you test all pancreas patients, just like in colon, you're going to find that about 10 to 15% of patients carry a relevant gene to their health. And even though it may not be immediately relevant to the treatment of their cancer at the time, it may benefit close family members and others to help make them more aware of cancer risks of breast cancer, ovary cancer, prostate cancer, and others. So we think that this is a huge benefit in the field. And I think that in the years to come, we're only going to see more testing that opens up based on a diagnosis of cancer. And that may be for all colon cancers and other cancers out there. The last thing that I just wanted to make a point on again is that one great value of the genetic testing in pancreas cancer is that it identified, or that it's useful in identifying mutations that may actually be targetable. We participated in a large clinical trial called POLO, which identified that patients who have pancreas cancer who have a BRCA mutation can be treated with a specific targeted therapy, which can prolong their disease-free survival. This is part of the dream and the ultimate goal of genetic-based therapy and oncology. So I think this has again been an enormous advance for the field. I don't want to take up too much time. We'll have lots of time for questions, but I really thank everyone who attended tonight. And I'm going to switch over and introduce my next colleague on the call, who is Hannah Campbell. So Hannah Campbell is the newest member of our team in the Department of Clinical Genetics. Hannah joined the Fox Chase Risk Assessment Program in the spring of 2020. It was very difficult for her. She literally took her first job ever in the middle of COVID just starting. So I think Hannah has really had a tough time, but starting a job that way, but has been a great addition to our staff. She completed her master's in genetic counseling at Johns Hopkins University and the National Institutes of Health training program, where her research explored how genetic counselors can play a role in patient access to mental health support. Since joining our team, Hannah helped establish a new genetic counseling clinic at Temple University Health main campus in North Philadelphia. This was a huge benefit to our program, and I'm eternally thankful at Hannah at taking on that big endeavor. So Hannah, you're up.
Thank you, Dr. Hall. So I'm just gonna kind of keep things broad and a little short and sweet, but I know some of you on this call probably have already gone through genetic testing and are pretty familiar with our program, but I wanted to go over some of the basics of what to expect if you were sent to talk to a genetic counselor and go through the genetic testing process. But I think before I dive into that too much, I just want to give a little bit more context about what are we even testing for when we do genetic testing. So can you go to the next slide, please? So when we're doing genetic testing, we're looking at your genes, which are just sets of instructions that tell your body how to do different tasks. And the genes that we focus on with the testing we do with our clinic, they're all involved in protecting your body from developing cancer. Some people are born with one of these genes that has a mistake in it. It's not doing that job very well. We call that a mutation. And if someone has a mutation, then they have a higher risk for getting cancer over their lifetime. And like some of my other colleagues already mentioned, most cancer is not related to one of these mutations in someone that they're born with that then gets passed down in a family. Most of the time, cancer is what we call sporadic, where it happens by chance, or familial, where we see more cancer in a family than we might expect, but we do genetic testing and we don't find a genetic explanation for those cancers. Next slide, please. So if most cancer isn't hereditary, then why are people being sent for genetic testing? So there's several things that we look for in families, patterns that we look for that make us more concerned that there might be a genetic risk getting passed down in a family. So one of those red flags would be cancers being diagnosed at a younger age than we might expect. If someone has a rare type of cancer, such as ovarian cancer or a breast cancer in a man, or if someone has more than one diagnosis of cancer over their lifetime, or, of course, a strong family history of cancer, like 2 or more people in the family with the same type of cancer, or cancers that can be linked to the same gene. And then, of course, if someone is getting cancer treatment, like Dr. Hall just spoke about, and, my other colleagues just spoke about, it can help with figuring out what kind of treatment might work best in you. Also, if some people come in and say that their family members have had genetic testing and they've found out, oh, my father or my sibling had testing and they might be at risk for having inherited a genetic mutation. Next slide, please. So if you are sent to a genetic counselor, here's kind of an overview of what to expect. So I always start off the session. I really like to get to know the person that's in front of me, understand what your goals are for doing this testing, maybe what your experience has been like with a cancer diagnosis or watching family members go through a cancer diagnosis, because ultimately this testing is going to be hopefully to benefit you and your family. We also talk a bit about your cancer history, what screening you've been doing, and just get an understanding of where you're at with all of that. We do take a very detailed family history just because that can help us understand what the likelihood might be of us finding a genetic mutation if we do end up doing genetic testing. And so we like to get information about who's had cancer in the family, what age they were diagnosed, what type of cancer they had, of course, if that information is available. And then I kind of go through all the logistics of the genetic testing, help guide you through that process if you do decide to do genetic testing. And then once the results are back, I'm also involved in explaining what those results mean, what kind of screening you might need to be getting if we find out you have a high risk for cancer, and if anyone else in the family needs to get genetic testing. So I go through the next steps with you. Next slide. So we've already talked about a bit, genetic testing is just one piece of information that we can use to understand your lifetime risk for cancer. So it's just one piece of the puzzle. So a lot of times we do genetic testing in someone who has, say they have a strong family history of cancer and we don't find that they have a genetic mutation. We don't ignore that family history. We still use these other pieces of information to help you guide you in what kind of cancer screening you should be getting to be as proactive as possible to try to either catch cancer early or prevent it. So, this can still be a useful process even when we don't find a genetic risk when we do genetic testing. So I think I kind of wanted to wrap up by just giving some advice about what you can do to prepare for a genetic counseling appointment if you are sent to a genetic counselor. So I think one thing I tell a lot of people to do is talk to your family and write things down. Write down if anyone's had cancer in the family, if they know what type it was, if they remember roughly what age that person was diagnosed. I know this is not an easy process for everyone. Not all families like talking about the fact that there's been a cancer diagnosis. I have encountered many times, though, people who come to talk to me and say, oh, I asked my mom about the family history of cancer and I had no idea that my aunt had ovarian cancer, for example. So it can be useful to probe a little bit and gather some information before you even meet with a genetic counselor. And then I think it's also important to keep in mind, though, that it's okay if you don't know all of your family history. We can still do a lot with, whatever we do know. And we just kind of work with what we got and guide you through that process. There are, like Dr. Hall said, there are options to do genetic testing, even if insurance doesn't cover it. Things are constantly getting more affordable for people to go through this process. And then if you're sent to us because you had a family member who had genetic testing and they found a mutation, it's always really helpful for us if you're able to get a copy of that report before you meet with us, because then we know exactly what to look for. And again, this is not always possible for everybody, but can be something that people don't necessarily realize before they meet with us, that it could be helpful to at least try. And, if you have had genetic testing in the past, I think we already mentioned this, but there's a lot more that we're learning every day about cancer genetics, and we're able to do testing for more and more genes all the time. So if you had testing many years ago just for a small number of genes, you can always check in with your genetic counselor, or if you had testing with us, you can call our office and just ask if it makes sense for you to have an update to your testing, because there are things that we could have missed if we did testing a long time ago and didn't revisit that. And I think my final point is just that a lot of people come into this process, sometimes they're nervous, sometimes they feel like they have to do this if they meet with a genetic counselor. I think that Keep in mind that this is always up to you whether you want to get genetic testing. The point of meeting with a genetic counselor is to talk through your specific situation with your personal history, your family history, and figure out how concerned we are about there being a genetic risk in the family and the pros and cons of you doing this testing. So it's really just a conversation, and then, whenever, if and when you decide to do testing is up to you. So with that, I'm looking forward to hearing all your questions, and that's really all I had to say. Thank you so much for having me.
Thank you very much, Hannah. That was excellent. And I also look forward to the questions. All right, our next speaker is really our guest speaker. This one speaker who comes from outside of our department. So I'm thrilled he took the time out of his schedule tonight to join us. Next, we'll have Dr. Rishi Jain. Dr. Jain is a GI medical oncologist and nutrition researcher with interests in the role of diet in cancer prevention and survivorship. He has a master's in nutrition, and he's board certified in obesity medicine. He has a number of ongoing studies at Fox Chase looking at the role of novel technologies to assess dietary patterns in an effort to improve dietary habits in patients with both early stage and advanced cancers. And of note, we're also trying to get one of these same studies going in our hereditary genetic risk population. We've been working on that, so we will get that going as well. He also has an interest in reducing disparities in dietary patterns and food insecurity among different racial and ethnic groups. He's also planning interventions to study the intersection between genetic cancer risk and lifestyle habits, as I just said. So thanks again, Dr. Jain, for taking the time out to talk to our patients tonight.
Thank you, Dr. Hall. So I'll try and keep this relatively short because I know we want to get to questions soon. So one thing I just wanted to point out is that, most of us have long understood the relationship between cigarette smoking and cancer risk. But if you look at many other lifestyle factors in combined, they could actually end up exceeding the attributable risk in terms of different causes for cancer. So as you can see, excess body weight causes around 7.5 or 8% of cancers. Alcohol contributes to about 6% of cancers. Poor diet, close to 5%. Physical inactivity, 3 or 4%. So collectively, those lifestyle factors are actually major causes of cancer, and you're now kind of starting to learn a little bit more about the intersections between genetics and cancer and some of these lifestyle factors. Next slide, please. So, cancer evolves because the normal cells, can slowly develop abnormalities and become precancerous and then cancerous. And along that process, there's a variety of factors that can contribute to, that process. So there's host factors. So that includes genetics, as many of my colleagues have been talking about, gender, someone's microbiome, and other factors in a host or a patient can contribute. Then there's also diet and lifestyle factors. So things like nutrition, fiber intake, other things can affect this process, and other environmental factors such as infections or environmental carcinogens can all collectively impact this cancer risk. Next slide. So there's an organization which is sort of leading the efforts in terms of summarizing the risk of, or summarizing the different lifestyle factors that increase cancer risk. And they came out with their summary a couple years back, and these were kind of their main lifestyle factors, which they thought if you follow could reduce your risk of cancer. So being a healthy weight, being physically active, eating a diet rich in whole grains, vegetables, fruits, and beans, trying to limit consumption of fast foods, foods that are generally processed and high in fat, limiting consumption of red and processed meats, limiting consumption of sugar sweetened beverages, limiting alcohol, Try not to use supplements specifically for cancer prevention, and if for mothers breastfeeding. And these specific factors have also shown some evidence even in patients with hereditary cancer risk. So for example, in Lynch syndrome, there is some evidence that patients who are obese have an increased risk of Lynch syndrome related cancers, or I've also seen data for patients with Lynch syndrome who eat more fruits or eat less processed foods might have a lower risk of developing polyps. So these factors are relevant in the hereditary cancer population as well. Next slide. So the reason why colorectal cancer and lifestyle is a hot topic is because that group, AICR, actually estimates that almost half of colorectal cancers could be prevented with a healthy lifestyle. So that doesn't mean that all colorectal cancers are related to lifestyle, but many are. And we are trying to find ways to help people improve their lifestyle habits to reduce that risk. Next slide. The reason why colorectal cancer and diet are closely linked is largely because the colon is in constant interaction with the things we eat and the substances that come with the things we eat. So as you can see, in a patient who has higher red meat, processed meat, animal fat intake, there's a lot of bad substances that can accumulate in the colon, like bile acids and other polyphenols. And those substances can interact with the colon lining and lead to carcinogenic effects. Whereas in a patient who's eating more whole grains, fruits, vegetables, you have a better balance of some of the good factors and the bad factors, and that can lead to anti-inflammatory and anti-cancer effects. Next slide. Last thing I just wanted to show is this was a very recent study that was published where they looked at the interactions between this thing called the polygenic risk score, which they look for a variety of genetic variants that put people at risk for colorectal cancer. And they looked at that in relation to healthy lifestyle. And as you'll see in the first part of the figure in A, if you look at the low polygenic risk patients, the interaction between the healthy lifestyle and the genetic risk is not very strong. Whereas on the right, in the high risk, you can see that there's about a 1.2% excess risk of colorectal cancer in those patients who have a high genetic risk and an unhealthy lifestyle. Similarly, for a different type of healthy lifestyle score, that excess risk with a high genetic risk and an unhealthy lifestyle is almost 2%. So this is just some of the emerging data that patients who have genetic risk and have unhealthy lifestyle or a healthy lifestyle could hopefully reduce their risk of a cancer. And thank you very much. Appreciate it.
Thank you very much, Dr. Jain. We appreciate you spending your time to come out and talk to us tonight. Our final, but certainly most revered speaker is the leader of this group and founder of our program in our department, someone whose career I admire greatly, and who I think really had a great vision to see that where genetics would take the field of cancer and prevention. I'm gonna, before I introduce Dr. Daly, I'm just gonna read, I asked everyone to write a couple paragraphs about themselves to introduce, so I'm gonna just read what she wrote to me. She wrote, my career started as a teacher in a one-room high school in a small village in Kenya. The thirst for knowledge I saw in the boys I taught showed me the power of education, which has motivated me to make education a central part of my career as a physician. I also learned in Kenya the importance of public health, as I saw people dying from diseases that are totally preventable. Understanding the importance of genetics in cancer has now given us a powerful tool to prevent developing many types of cancer, not only in individuals, but in their family members as well. Dr. Daly has made over her career a number of enormous contributions to our field, both personally, but also as being a great collaborator. And to this day, even though Dr. Daly actually, if anyone doesn't know, is streaming from Texas because she actually lives in Texas, but she continues to come to all of our pedigree reviews. She still has a incredibly active grant and research list and collaborative list. It's clear, one thing that motivates me as a researcher is it's clear watching her work is that the joy of doing research and working with other people clearly drives her. And I think almost anyone in research medicine will say the same thing, but it really is inspirational. So I don't want to take any more of her time. Our next and final speaker is Dr. Mary Daly.
Thank you. It's a real pleasure to speak with you tonight, and I'll try and be brief so that we can get to the questions. So my job was to sort of touch on how we all got started on this and where we're going from here. The middle part of that is where we are now, and that's what you've just heard from our speakers. So I want to just tell you a little bit about how we started in a very naive way. I came to Fox Chase in 1989. I was trained in medical oncology and breast cancer, and I had just spent 6 years in the Air Force as the only female medical oncologist in the Air Force. So I had built up a large practice of breast cancer patients because they wanted to have a female oncologist. But that motivated me when I came to Fox Chase to want to move beyond just the care of patients, many of whom would die, to finding a way to prevent it so that we would be able to make a sea change in the disease. And I thought at the time that genetics would be the tool that we could use. You will, by the way, be seeing my little kitten going back and forth across the room. He's at the crazy cat stage right now. So I came here very naively, and when word got out that that's what I wanted to do, I got handed a little metal box of index cards by Ginny Martin. Some of you may remember Ginny, wonderful nurse here at Fox Chase. And in it was cards with lists of names of women who had relatives with ovarian cancer, who wanted to know what their risk was and what they could do about it. And of course, we didn't know that much about ovarian cancer at the time. So I decided to start with some evening sessions and brought together some of these women for like an information session. And as I was leaving after the information session at about 8 o'clock in the evening, I went to the parking garage to get in my car, and there was this whole group of women standing together and continuing the conversation amongst each other. That's how much they were motivated to want to share their stories and learn more. So I learned the importance there of education and partnership and having people in these high-risk families sharing their information with each other. And of course, fast forward to the mid-90s when we learned about BRCA1 and 2, and very quickly tests were available for clinical use. We could also test around that time for Lynch syndrome. And so, although there were a lot of naysayers who said, oh no, we're not ready to use this information, it will make people too nervous, they'll be anxious, that we should all have them see psychiatrists before they get tested. My feeling was that knowledge is power. And even though we don't know everything there is to know about these genes, let's begin somewhere, but let's do it with research as the foundation so that 5 years later, we would know something more than we did at the beginning. And that's kind of been the cornerstone of our group, that we try and do everything we can in the context of a research situation so that we're constantly learning and can apply that to the next set of questions that arise. So many of you who are listening in have probably filled out innumerable surveys of ours, and I want to thank you for that and been part of a lot of our different research projects, which are truly ongoing. And of course, over the next 25 years, we've learned about more genes, and you've heard a lot about that from our previous 5 speakers. So going to the idea of where do we go from here, I can't possibly touch on all the different ways that we're evolving and moving, but I want to highlight a few of them. One of them is, when you think about it, most women who get breast or ovarian cancer don't have one of the known mutations. What's going on with those women? What are the causes of cancer in those women? And I think Dr. James touched on some of those causes. And even in the families where we say, let's find a Lynch syndrome mutation or a BRCA mutation, not everybody who has a mutation gets cancer. What's protecting those people? What are the modifiers of these genetic risks, like diet or lifestyle, or other genes, or things in breast cancer like breast density, or the strength of the family history? And I could go on and on. But there are now, there's a lot of excitement about creating what are called risk scores or personal risk models, where you can take all of these kinds of factors about an individual person, put them into a computer that will weigh them based on what we know about the strength of that risk factor. And instead of telling someone, oh, you have about a 40 to 80% risk of cancer, we could be able, for instance, to say your risk is specifically 33% or 63%, so that people can make much more informed decisions about where they're going. Another thing that we're seeing happening is, and I think this will become common in all of oncology, because we can now test tumors to see what those tumor mutations are that will guide treatment, and then also look in the germline to see if it's hereditary or acquired. I think that what we're going to see in the future is become very common that all new cancer patients will have their tumor tested and their blood tested. And in addition to having personalized risk scores, they'll have personalized treatment plans, so that based on all of that information, not on any one thing alone, we can be more precise in how we treat people. Now, there's a lot of new technology coming along, which I admit I don't know as well as I'd like to. You've probably heard of things like CRISPR, where you can go in and change genes in someone we know that has a genetic mutation. You probably heard of something called liquid biopsies, or this is where you take a blood sample and look for circulating DNA that has come from a tumor but is now circulating in the plasma, and can tell you what kind of tumor it is, where it's coming from in the body. These are all very exciting things that are currently in a research phase that I'm sure we'll hear more about. And the way technology moves, I'm sure there are things that we can't even imagine at this point. But it's such an exciting field to be in. And I feel so honored to have been part of it all these years. And I'm looking forward to what happens next. So thank you very much.
Thank you so much. That was awesome. I think, again, still when you speak about your excitement of the field, it always gets me excited. So I think that's the infectious part of genetics in cancer. I am literally drowning in pink sticky notes that I've tried to take notes of all the questions that have come in. There are a lot of questions. I'm going to try to direct these to some degree. I'll just ask our panel, I know everyone's smart and loquacious, to try to, so that we can, everyone can get a question and we can try to get through some of these, try to answer them efficiently if you can. I'm going to start with a great question that came in for Dr. Obeid. So can the children of a man who is diagnosed with prostate cancer have an increased risk of different genetic kinds of cancer, and what would those be?
Yeah, so it all depends. If there is a genetic predisposition that was found and it was passed on to the children, then that could increase the risk of whatever that gene mutation is associated with in terms of the different cancers. Now, if somebody has a prostate cancer and they did genetic testing and they did not have a genetic predisposition, the children, so the men or the sons of that man with prostate cancer, they do have an increased risk just by the fact that they have a first-degree relative with prostate cancer. And this has been studied, in different families, and the risk is there. I think we just understand about some of those factors. So that are hereditary, so genetics. Some are familial, but then the rest we just don't know.
Okay, thank you very much. Dr. Whitaker, there was a question for you as well. So do you, for women who are at higher family or genetic risk, do do you recommend self-breast exam? And there was also sort of a follow-up to that about would sort of a high-risk clinic be a better way to sort of get screening than to do self-breast exam? Or they're just looking for your opinions on that.
Yeah, so, self-breast exams, they've been a little bit controversial in the sense that some data has shown that maybe they don't add that much in terms of early detection. And I think it's mostly because many women don't feel comfortable examining their own breasts, and they don't really know, what's normal versus abnormal. But I will tell you that, especially as a breast medical oncologist, I have seen many patients find their own breast lumps. So I generally do counsel women that they should do monthly self-breast exams, really with the idea being that they examine their own breasts enough that they start to feel comfortable with what's normal versus abnormal. That being said, I think, one of the benefits of a place like Fox Chase is that we do have this high-risk breast cancer screening program where, if I see you in clinic or Dr. OB sees you in clinic, we're still going to encourage you to do breast self-exams, but we're also going to be making sure you get a clinical breast exam every 6 months, which I think is an added benefit to a program like our high-risk program at Fox Chase.
Great. Thank you very much. Dr. Jane, a few questions for you, and the similar themes of all the questions. So part one is organics. In terms of the field of nutrition, is there a benefit for cancer risk in organic food versus not, or can you talk a little bit about that? The follow-up question was also about supplements. You mentioned supplements sort of in a slightly negative way, and so vitamins and supplements, what are your thoughts on that?
Yeah, so to start with the organic question, I have seen some data that from a population level, people who eat more organic foods might have slightly lower risks of certain cancers, but I think the big caveat to that is that people who eat organic foods are probably healthier in other ways as well. So there could be some confounding variables that, muddy the waters a little bit. So it's not entirely clear if eating the organic food is the, factor that, is beneficial, or if those people are just healthier in general. So as of now, the guidelines do not recommend that you have to follow an organic food diet. In terms of supplements, if you have some sort of nutritional deficiency, then absolutely a supplement might be necessary, and that's something your doctor would advise. But in general, the community feels that it's not just the specific, vitamin or mineral. It's really the vitamin or mineral in the context of the whole food. So there's a lot of other substances you're getting when you eat a fruit, aside from just the vitamin C, which you would take in a supplement, for example. So trying to get those types of things from whole foods is the recommendation.
Great. Thank you very much. Hannah, there were a few questions for you, actually really, really good questions about genetics. I'll say both to you, and then I'll give you the chance to answer. So the first one was, if a grandparent tests positive for a mutation in a gene, but then their children test negative, are their grandchildren, through that child, still at risk? There was also a question, they've heard this term VUS a lot. What the heck is that?
Great questions. So to answer the first question, so if the grandparent has a genetic mutation and then that person's, the parent does not have it, then it stops there. So it just means that that person did not inherit that genetic mutation from the grandparent. Anytime someone has a genetic mutation, it's a 50-50 chance whether it gets passed on. So it's not a guarantee. So if it doesn't get passed on, then that child cannot pass it on then to their children. And then the other question about VUSs. So this is a type of result that we can get when we do genetic testing that can be a little tricky. So sometimes we get positive results where we find a mutation. A negative result means we don't find a mutation. But then we have this kind of gray area called a VUS, which just means that the lab that we send the test to sees a difference in your gene, something we call a variant. Everyone has differences in their genes, which makes them all unique people. Some of those differences are completely harmless, but some of them can, be harmful and increase the risk for cancer. So if the lab is not sure which direction that variant is leaning, then they'll say, this is a VUS. Most of the time it ends up being harmless. Sometimes it doesn't. And so we usually just take those types of results and put them on the back burner until we learn more information. And it can take a while sometimes. So it can be something that we end up having long conversations with families about to try to talk through, what that result means. But we usually just say, don't do anything with this right now. We're just going to wait and see what we find out in the future.
Thanks, that was great. There, for kind of Dr. Daly, Dr. Whitaker, and Obeid, it sort of orbits around all three of you. There were a few questions of beyond, screening for breast cancer. Are there other things that high risk women can do? And one question also sort of got at the question of is sort of chemo prevention still around in the high risk breast setting? So I don't know if Dr. Daly, maybe if you want to start, and then others could answer too.
Yeah, so that there have been several very large chemo prevention trials in women to see if you can reduce the risk of breast cancer. And the two types of drugs specifically have been tamoxifen and the aromatase inhibitors, both of which have shown a significant reduction in breast cancer risk. Unfortunately, we didn't ever test the women in those studies for whether or not they had a mutation in one of the breast cancer genes. So there really is no data specifically in that population of women. And you could speculate that maybe the progression of disease is different if it's being driven by, say, BRCA1 and may not be as responsive to something like tamoxifen. So we can extrapolate from those large studies, but we don't have specific data yet. And it's, in my experience, it hasn't been something we turn to that often.
Okay, thank you very much. Did Dr. Obeid or Whitaker, did you want to add anything to that too?
The only other thing I would say, I touched on it very briefly, but just to reiterate the point that screening is an option in this intensified screening, but the other option, depending again on the type of mutation you have, is that you can consider preventative surgeries to reduce that risk of breast cancer. And again, we know that's the most effective way to reduce your risk of breast cancer.
I think one more thing that we have learned also over the years and from research, Dr. Daly has participated with, collaborated with others, that women who have a BRCA1 or 2 mutation, and if they do get their ovaries taken out at an earlier age, potentially when it's recommended to, that might also decrease the risk of breast cancer in the future. So we know certain things that they can do. So it's one added benefit sometimes. So in surgery that they maybe not want to have.
Great, thanks. That's great. I think this question is probably sort of directed at Hannah, but sort of all of us on the call is sarcomas. Are there genetic risks for sarcoma, and should patients with sarcoma think about genetic testing?
The short answer to that question is yes. I think we always, with any type of cancer, talk about it in context of when it was diagnosed, what type of sarcoma it was, and look at the family history and put all that information together to figure out whether genetic testing makes sense.
Yeah, I agree. I'll say that I think probably in our practice, I probably sort of see the most patients with sarcoma who come through for various kinds of testing. And as Hannah indicated, there are sort of types and subsets of people with sarcoma. For instance, GIST tumors in some settings, we do testing. There are actually some families who have Lynch syndrome. They're rare, but some of the MSH2 families who have Lynch syndrome. That's one of the Lynch syndrome genes. We do sometimes see sarcomas in those families, and we have a small group of families here at Fox Chase who have Lynch syndrome and sarcoma. Also, families who have a gene known as TP53 can sometimes get sarcomas as well. So sarcomas and hereditary risk do overlap. And I would say kind of as we are, as Dr. Daly alluded to, doing more tumor testing and more patients are getting some sort of genetics either done on their tumor or their germline or both, I think we will find more and more that that there are some genetic links of sarcoma to hereditary risk. Dr. Jane, there was another question that came in for you. So is there, because you mentioned this in your talk, is there a safe amount of alcohol use, and where would you peg that?
So the AICR and other organizations make a recommendation that if you can avoid alcohol altogether, that would be ideal. If you do consume alcohol, I think the current guidelines are trying for men to limit it to less than 2 drinks per day, and for women, less than 1 drink per day is still kind of the gold standard. But if you can't avoid it altogether, that's a bonus.
There's kind of a tougher, more technical question that I guess I can open to everyone. So someone asked specifically about RAD50. So perhaps someone in the audience tested positive for RAD50, but is this gene still, do we consider this sort of still relevant for breast or I guess ovarian cancer risk? Are we still testing for this?
So, I mean, I'll start. Others may have things to add. I mean, I think RAD50 honestly is one of our most challenging genes. I mean, RAD50 is, I believe, still, and Hannah, you may be able to correct me, I believe RAD50 is still on many panel testing for different types of cancers. You know, the person who asked the question is exactly correct in that we had some earlier studies that suggested it could increase your risk of breast cancer, and some studies showing even potentially that it could increase your risk of ovarian cancer. Many of those studies were small and we had kind of limited data. I will say as we continue to study RAD50, we think that there's less of a associated breast or ovarian cancer risk, but I think that the verdict is still out a little bit. And I think it's especially challenging if you get genetic testing done and you have a RAD50 gene, because it unfortunately is one of the genes where we truly just don't have very good guidance in terms of what we should be doing for your screening or whether we should be making any kind of recommendations related to surgeries to reduce your risk of breast cancer. Dr. Daly, I know you probably think about this too, heading the NCCN. I don't know if you had anything else you wanted to add.
We almost wish that RAD50 wasn't on the panels, because even if there is a risk, it's probably not large enough to do anything different about. But being that it's on the panels, over time we'll learn more about it. We'll be able to say yes or no, we should look for it. But you're right, it's one of the ones that has the biggest question marks about it.
Thanks, you guys. I got a question, and it is something that I wanted to talk about just briefly about pancreas cancer screening, sort of like, are we there yet? And again, the short answer is we're getting there. Certainly, there have been guidelines or at least expert statements that have come out of the gastroenterology community and others about which individuals who have high-risk mutations or have had a high-risk condition like a history of pancreatitis or a family history of that, which people out there should be considered to perhaps pursue pancreatic cancer screenings. I think we've come a long way in identifying those individuals. And just to give people on this webinar a flavor, some of the genes we've spoken of tonight, like BRCA 1 and 2, like ATM, the Lynch syndrome genes, and several other genes in certain contexts of family history are considered high enough risk to consider pancreas cancer screening. The second part of this question is the screening really where we want it to be? And again, I would say we're getting there. I think we've identified the best modalities we have right now, which are MRI screening of the pancreas and using a technology called endoscopic ultrasound, which uses an upper endoscopy plus an ultrasound probe. These have definitely improved our ability to visualize the pancreas and to find abnormalities like cysts that may become malignant. The challenge still is, who do we move forward on a major surgery for to remove a potentially malignant appearing cyst versus who do we watch? There are still a lot of challenges in that part, but I do think in my years in this business, we have moved forward, and I think there's a lot of promise. And there still are a number of trials out there for patients who have genetic risk of pancreas cancer or a family history, which those trials are definitely thirsty for patients so that we can prove what are the right ways to screen.
This is
Dr.
an
V,
example of why we need research.
absolutely, absolutely. If we can get more people to help us answer these questions, we'll all be in a better place. Dr. Obeid, so a question came in about, just to summarize again, what you consider as the best kind of screening for a man who has a genetic risk of prostate cancer. What would you recommend, to that man? And maybe just say a few words about the high-risk clinic we have here.
So the recommendation is still once a year prostate exam and the PSA test. I would say that the PSA test is probably the more accurate one, or at least the more sensitive one to pick up something. It's done once every year. Now, what we do differently at our prostate risk clinic is that we follow the number of that PSA a little bit differently. And what we've learned over the years is, because our high-risk population, they are considered a high risk to getting prostate cancer. Probably 1 out of 4 of those diagnosed with prostate cancer have been diagnosed at a PSA level that wouldn't have triggered otherwise any kind of workup if it was not, in that particularly high-risk clinic follow-up. So the level that typically is, an alarm is usually a 4. In our clinic, we look at it 2 as an initial alarm, that we either repeat the PSA a few months later, or we directly refer them to one of our urologists who work with us in the clinic. So this is, and then sometimes, individuals would not want to go for any further biopsy, and we can just say, let's wait and repeat the PSA just a few months, and depending on that level, that's how we determine.
Great. Thank you so much for that. So we're getting close to our hour. I think there's still a lot of questions. What I'm going to try to do, just for people who logged on and watched, we'll try to distribute some of these and answer them. I did want to give Dr. Daly the chance to answer one last question, because I think it's a really good question, which is, Dr. Daly, in your years of experience in this field, like what's been the biggest surprise to you in the field of genetics and what you've sort of seen evolve over the years? What sort of surprised you the most?
I think this may seem trite, but I think the realization as we went along that all cancers and probably all diseases are basically a derangement of some sort of our genetic material, whether it be because we've inherited an abnormal gene or things in our life just affect our genetic material so that they eventually get to a point where these diseases can occur. So it's kind of become the basis for understanding all diseases. And that's made me realize how little we really do understand them, because there's so many complex components of genes in cells that, again, we need to continue to do this kind of research. I would like to say one last final thing, though, that's a little aside from this question, is that I really want to thank all of the people who've participated in our research and who've been partners with us. And going forward with all of these more complex things, we're going to need your help along the way to really get a good understanding of genetics and how it might affect your life. So thank you very much.
Yeah, I think that's a really great point. We would not, I always say this to my patients in oncology, we would not know what we know about the drugs that we use, and we certainly would not know what we know about genetics right now if we didn't have interested and generous patients out there who took a chance and participated in a lot of the research that we've conducted over the years, and it's that generosity that's helped move the field forward and has put us where we are, and it's that generosity that's going to move us even farther forward. And every single person on this call has participated in research and has great ideas about how to move this field forward. So we look forward to doing that as a partnership. It's been a really fun evening. It flew by. Again, I really want to thank, just in order, our sponsors for sponsoring this event, our advocacy groups, the group from Fox Chase who helped put on the event and made this really easy for the rest of us just to log on and do our part. I want to thank all of our panel for taking the time to prepare their talks and share their expertise with us. In particular, Dr. Daly for logging in from Texas and giving us insights on the field. We will certainly be doing this again down the line. So if you have comments on things you'd like to hear in the future, please send those also to the staff that ran this webinar, because we'd be happy to address further things down the line. And we will answer all the questions. We'll be getting a list of them from the staff who ran the meeting, and we'll get those answers back out to everyone. So again, thank you again for spending an hour and a half with us this evening. Have a great night from the Department of Clinical Genetics.